Reaction was no distension, think again. But when you look carefully at the gallbladder fossa, the gallbladder isn't distended, but there was a second fluid collection in the gallbladder fossa. And when you look a little more carefully, you can see that this gallbladder is actually perforated and there's a pericholecystic abscess here. So once the gallbladder perforates, it decompresses itself, and that rule of distensibility no longer holds true. So what about gallbladder perforation? Well, it's not as common as gallbladder gangrene, but it is important because of the high mortality rates. It comes in three flavors. It can be acute, where you get a generalized peritonitis, but more often it's subacute, because the gallbladder is inflamed for some time, the omentum has come up and walled off the inflammatory process, so you get a pericholecystic abscess. And then more chronic cholecystitis can lead to internal fistulas, sometimes to the bile duct, but more often to the duodenum or occasionally to the hepatic flexure of the colon. So here's an example, again, about a 5-day history of pain. We see this large stone in the gallbladder neck. Note that the gallbladder isn't particularly distended, but there's a process here in segment 5 of the liver beside the gallbladder fossa. We look a little more closely at that, and in a septic patient, it has all the hallmarks of a liver abscess. And then, of course, we go back and look a little more carefully at the gallbladder, and then we can actually identify the site of perforation in the gallbladder wall. And the literature tells us that CT and ultrasound are about equally sensitive at demonstrating that site of perforation. Now, in our practice, before our interventional radiologists drain an abscess like that, they generally like a CT scan to get a better overview. And here's the CT scan on that patient showing this large abscess in segment 5 of the liver. And if we take a select image here, CT also beautifully shows the site of perforation. Now, an unusual form of acute cholecystitis is emphysematous cholecystitis, gas-forming bacteria. Not all these patients actually have gallstones, and some but not all patients are diabetic, more common in men, about 7 to 3, and an important condition because the gangrenous rate and the perforation rate are much higher, and therefore the morbidity and mortality of this condition is much higher than the usual form of calculous cholecystitis. Here's a nice example, the very best image we could get of the gallbladder fossa. Notice this very echogenic gallbladder wall, but the important finding here is the shadow that that wall brings about. And rather than a nice clean shadow that we would see from calcium, this is a dirty shadow or reverberation artifact from gas. Now, it's a difficult diagnosis to make with ultrasound, so we have a very low threshold for CT scan to confirm the diagnosis, and this is a non-enhanced CT done shortly after the ultrasound, which shows gas not only in the gallbladder lumen, but also in the gallbladder wall. Now, how do we contrast emphysematous cholecystitis with a gallbladder filled with stones? So our emphysematous cholecystitis is on your left, and on your right we have a distinctly different image, because here we can actually resolve a very thin echogenic line, which is the gallbladder wall, and then there's a second acoustic interface that's more irregular, which brings about a very clean shadow, which is distinctly different from the reverberation artifact from gas. And this is called the wall echo shadow sign, or the west sign of a gallbladder filled with gallstones. So that's the west sign. And here's another interesting case. Challenge yourself on this one. I've lined them all up. We have emphysematous cholecystitis, and then we have the gallbladder filled with stones. So what's happening with the third gallbladder I've shown you? Well, if you look at that case, I would suggest that the wall in this case is indistinguishable from the wall in the emphysematous cholecystitis. But the teaching point is the shadow trumps everything. So this again is a nice clean shadow coming from that gallbladder wall, so it's going to be a calcified wall or a porcelain gallbladder rather than emphysematous cholecystitis. Now this was an elderly woman. She was an inpatient in our hospital and she was brought down with acute right upper quadrant pain. She was on a medical floor and she was in hospital for a different reason. This is the best image we could get of the gallbladder fossa, and it demonstrates a large gallstone surrounded by some isoechoic material. And the question arose, well, what was going on? So the one great advantage of ultrasound is you get to see the patient, you get to talk to them, you can read the chart. It was pretty clear that she had an infective process ongoing. She had symptoms in the right upper quadrant. She was tender there. So we interpreted this as probably an inflammatory process rather than tumor, and we said it's probably acute cholecystitis. And she went back to the floor, and because of her other medical conditions, she was managed conservatively with intravenous fluids and antibiotics. And then a couple of days later, the surgeon came back and said, do you remember Mrs. So-and-so? And we said yes. And he said, well, funny things happened. Her pain has changed. She has a distended abdomen this morning, a more generalized pain. I think we should re-image her. And we said, well, let's do a CT scan because the abdomen's distended. And here are images from the CT. And now we see gas in the gallbladder. There's gas in the biliary system. And of course, there's her gallstone. So the gallstone that we had seen on the ultrasound has now migrated through a cholecystoduodenal fistula and is now sitting in a mid-small bowel loop. You see some bowel thickening in the image on your left. And this, of course, is so-called gallstone ileus. Here's another more typical example of gallstone ileus where we see gas in the gallbladder lumen and the offending gallstones in the more distal ileum causing the bowel dilation that's evident on these images. And here's another case. This was an elderly woman who had emigrated from Vietnam who presented one morning with projectile vomiting. And this again was the very best image we could get of the gallbladder fossa, which showed gas with reverberation artifact. And immediately next door was this highly dilated peristalsing tubular structure with a stone within it. And we felt we knew what was going on here, but we elected nonetheless to get a CT scan, which always gives a better overview than ultrasound. And this patient, of course, has gas in the biliary system. Here's the stone in the duodenum that we saw, but there's a second stone here in the jejunum. And this, of course, is another patient who has a fistulous communication from the gallbladder to the duodenum with a high GI obstruction, so-called Bouvere's syndrome. Now, what about gallbladder torsion? This is a very rare condition. It's not something we routinely think about when patients present with acute right upper quadrant pain. It tends to occur in fragile elderly women. It's a difficult diagnosis, mostly because we don't consider it. It can be an incomplete torsion or a complete torsion, and only the minority of patients have gallstones. This is an example. If I can show you, this patient had acute abdominal pain. We put the probe on where the patient was tender, and it demonstrated this cystic structure with an onion peel appearance to the wall, an edematous wall. Note that that structure just behind is the distal aorta, so that gives you an idea of where that mass was positioned. It was here in the mid-abdomen. And again, if you're unsure, we didn't tweak to the diagnosis using ultrasound in this case. So CT is excellent to help clarify. And we realized when we did the CT that there's a neck from that structure going up into the gallbladder fossa. There's some beaking of the structure. And if we look critically at a selection of axial images, we see the cholecystic artery there with the gallbladder neck wrapping around it. And this is a partial torsion of the gallbladder, which is obstructing the cystic duct, causing gallbladder distension and the patient's clinical presentation. Now, what about pitfalls and mimics? So this is where the distensibility thing really comes into play. This patient had acute right upper quadrant pain. They were ill, but when we look here, the gallbladder lumen is not distended at all. It's completely collapsed. It's almost slit-like, and yet this patient has one of the thickest gallbladder walls that you are ever likely to see, this massive onion peel edema. And when we look at the liver, we can see that there's some thickening of the pericortical triads, and this patient, of course, has acute hepatitis with very dramatic thickening of the gallbladder wall. This patient should not go to the operating room. So if you misinterpret this as acute cholecystitis, you're probably putting this patient at some risk of further liver injury from the anesthetic agents. So again, know your patient, look in the chart, you realize the transaminases are up in the thousands, and you can confidently suggest that the diagnosis, or at least that the appearances, are in keeping with the diagnosis of acute hepatitis. A couple of more pitfalls. The patient on your left has an edematous gallbladder wall. There's pericholecystic fluid, but the clue here comes a little from the liver. The liver looks enlarged. It has bulbous margins, and then if you look at the inferior vena cava, you see that it's distended as well, and this patient, of course, has heart failure, which will cause these findings. Or the patient on your right, gallstone, there's gallbladder wall thickening, there's quite massive ascites, and although we don't see very much of the liver here, the liver had a nodular contour, so this is a cirrhotic liver. But where the distensibility rule has saved me are in cases such as this. Acute abdominal pain. It was a woman, she was about 32, and these are images from her gallbladder. And again, we see gallstones. There's even a stone in the region of the gallbladder neck. The gallbladder wall is thickened. But I want to draw your attention to this anterior wall. And instead of bulging outward, as you might expect in a truly distended gallbladder, it's convex towards the lumen. So that caused us to pause and say, well, this isn't a tensely distended gallbladder. I don't see evidence of perforation or a pericholecystic abscess. We best take a closer look. And when we went into the room, we realized that this patient had a much more generalized peritonitis. And when we looked carefully, we saw this. So this is with the patient lying left posterior oblique. We're using a linear probe. We had seen an abnormality with the general purpose curvilinear transducer. This was just to get a pretty picture. And this is focal enhancement of the peritoneal stripe with reverberation artifacts. So that's free air. And what this patient, of course, had was a perforated duodenal ulcer. And there is inflammation of the gallbladder because the inflammation has tracked up the duodeno-hepatic ligament, but acute cholecystitis is not the primary cause. And the CT confirmed the free air, so this patient had a perforated duodenal ulcer. Other pitfalls. This was another woman with right upper quadrant pain. There were no gallstones, so in an ambulant patient, acalculous cholecystitis is a distinctly unusual diagnosis. There was some pericholecystic fluid, but again, when you went into the room and spoke to the patient, I always say, where are you most tender? And when you placed the probe where this patient was most tender, it was actually infralateral to the gallbladder, and we got this image of a very thickened hepatic flexure of the colon with an inflamed diverticulum which is perforated. You can actually see a tract there of extraluminal gas, and this is focal perforation of acute diverticulitis of the hepatic flexure of the colon. So what about choledocholithiasis? Well, depending on the lab, the sensitivity is somewhere upwards now probably of 70%. Some labs probably do a little better. You'll find more CBD stones if the ducts are dilated. There were some advances with the development of harmonic imaging about 10 or 12 years ago, but really it takes time, and you have to see the entire CBD. In most patients, you have to examine the patient in different positions. So I find with the patient just lying supine, you'll often get a good visibility of the distal CBD, but to see it more proximally, you'll often do better with the patient left posterior oblique and luck intercostally. And there are other maneuvers that some people suggest. I don't often use them, where the patient sits up a little, you get them to drink water, go right side down to try and get water into the duodenum to act as an acoustic window. I don't often use that latter thing. And you need a pretty firm hand and scan around the gas in the transverse colon. Remember, if a patient's lying supine, colonic gas will rise into the transverse colon and will impede your view. So use lots of gels, slide the probe around and try and get a good acoustic window. So here's a case we can very quickly see there's quite dramatic intrahepatic bile duct dilation, but our job isn't finished. We have to find the level of obstruction. So we need to follow those ducts. Do they open into the CBD? Indeed they do. The CBD here is markedly dilated, and then we follow the CBD down because we still haven't demonstrated the level of obstruction, and here of course is the level, and then once you've found the level of obstruction, you have to try and decide the cause. Is it a stone or is it a tumor? So that's the big distinction. The clinical presentation may help you, and here we see a large stone. Now, some of you will say, but that stone isn't shadowing very well. You were talking a few minutes ago about the great shadowing from stones and calcium. And the reason for that is the technique here. We're using sono-CT. So we're using sono-CT. So there are multiple angles of insonation, and that disperses the shadow somewhat. So you have to be aware of that with gallstones, with kidney stones, and on some of the modern machines now, it's almost impossible to completely get rid of compound imaging or sono-CT. Now, you won't always see a stone with ultrasound even though you suspect it's there. And in our practice, at least on weekends and after hours, we don't always, or in fact we rarely have ready access to MRI. So you can use CT scan to complement the ultrasound to demonstrate a CBD stone. And here's an example. We thought there was a stone on ultrasound. We couldn't quite evaluate the level of obstruction well, and here is the level of obstruction on CT, and we see some high attenuation at the level of obstruction, but this is an enhanced CT image. So I challenge any of you to tell me confidently, is that a stone or is it an enhancing polypoid cholangiocarcinoma? I don't think any of us can tell for sure. So the teaching point is, if you're going to use CT, you must include an unenhanced scan. So once you have the unenhanced scan, then you can confidently make that diagnosis of a CBD stone. CT probably has a sensitivity of somewhere around 80% for CBD stones, but it's additive to ultrasound. So ultrasound and CT together are probably somewhere in the mid-80, maybe high 80s for demonstration of CBD stones. Still not as good as MRI, which is the gold standard. So if you can get an MRCP, do it, but I'm just saying in our practice, it's not always immediately available to us. Now, other things in the CBD can cause pain. This patient had a transjugular liver biopsy and returned within 48 hours with a history, rule out acute cholangitis. And what this patient has, of course, is blood in the gallbladder lumen and blood in the CBD from bleeding following the transjugular liver biopsy. And this is another interesting case given to me by Dr. Stephanie Wilson. It's an old case, but it's an interesting case because these are images from the same patient. And this is 10:30 in the morning. There's something linear in the CBD, and this is 11:30 the same morning, and the patient never had intervention. So that is not a CBD stent that has been removed. And of course, this is ascariasis. So this was a worm in the CBD, which was subsequently recovered. Here's another case. I scanned this patient myself. I remember it very well. There was a patient who had been jaundiced for about 2 weeks, and there was a concern about tumor. It had been a painless jaundice, but for about 36 hours prior to this ultrasound, the patient had developed quite severe right upper quadrant pain. And this was the very best image I could get of the CBD. We see the dilated intrahepatic bile ducts, the dilated CBD, and then there's this large cystic mass. So I was thinking of my classification of choledochal cysts, etc. But another important teaching point is if you ever see a cystic mass on ultrasound, always put on Doppler. So what a surprise I got, even with color Doppler on that mass. And that, of course, is a very large hepatic artery aneurysm. The patient went immediately for a CTA. Note that this aneurysm is irregular in shape. It's unstable. That's why the patient has pain. And that aneurysm was successfully repaired later that same day. Ascending cholangitis, pain, fever, leukocytosis, abnormal liver enzymes. To me, ascending cholangitis is a clinical and a biochemical diagnosis. Yet everyone wants an ultrasound to image these patients, and why is that? Really, you're doing the ultrasound to see if there's biliary obstruction. Because if a patient is sick with ascending cholangitis and the ducts are obstructed, they need to be drained. But when you do the ultrasound, you may also see thickening of the walls of the bile ducts. And often you may also see something in the bile duct, such as a stone. So here's an example, a cross-sectional image of the bile duct showing there is some biliary dilation. A stent has just been inserted, but this patient had quite a dramatic thickening of the wall of the bile duct. Here's another patient who presented one morning in septic shock, and the patient was resuscitated with some fluids and antibiotics in emerge, was brought up to ultrasound, and here's the portal vein. And then immediately in front, of course, we see the right intrahepatic bile duct and the upper common bile duct massively dilated, and then we see material within those ducts, sludge and stones. This is a better image of the common bile duct more distally. So if a patient is sick, or even if they're not sick, and you're confident you see a CBD stone, those patients can go directly for ERCP and definitive management. You don't need to do an MRCP necessarily if you've seen the stone with ultrasound and you're confident. So this patient was fully resuscitated, antibiotic coverage, and then went straight to the endoscopy suite and had her considerable burden of CBD stones managed. Recurrent pyogenic cholangitis, we do see this condition quite a bit in Toronto. There's a very large immigrant population in Toronto from many different parts of the world. The feeling is that there is an association with the liver fluke Clonorchis sinensis, and it's caused by very soft intrahepatic biliary stones. Surgeons tell me you can simply pick up these stones and you can just rub them between your fingers. They're very soft, and as a result, they don't always exhibit a very good acoustic shadow. Typical locations are segments 2 and 3 of the left lobe, segments 6 and 7 of the right lobe, and the characteristic finding, because of the recurrent infection, is parenchymal atrophy. And that'll deceive you if you don't have your wits about you, because the parenchymal atrophy happens slowly, and as it's happening, the adjacent healthy segment is hypertrophying to overcome and maintain the liver volume. So what happens is the diseased segment shrinks away to nothing, and the diseased bile ducts migrate to the liver surface. And because the stones don't shadow well, you can misinterpret that appearance simply as bile gas adjacent to a normal liver. So whenever you're scanning livers with ultrasound, pay attention to segmental anatomy by looking at the vasculature and making sure that all segments are present and accounted for. And here's an example. This is a scan of the right lobe of the liver. We're looking down along segment 6 here. Note it almost looks like reverberation artifact, but there's something here. And if you're unsure, you can always go to CT. This is another example, a funny looking left lobe of liver here. There's something going on. Is it tumor? Is it stones? Hard to say. There's a more linear echogenic line here with a poor shadow. But when you do the CT, the key is to do the unenhanced scan. And as we interpret this, we see these intrahepatic biliary stones, but note the marked atrophy here of segments 6 and 7. So these bile ducts have migrated all the way to the liver capsule, yet the overall morphology of the liver otherwise looks normal, and that's because the healthy segments 5 and 8 have hypertrophied to compensate. Liver abscesses, not uncommon at all. They can be pyogenic or amoebic. They'll mimic acute cholecystitis. Often there's no related cause, but often infection will have spread from the bile ducts or from the gut, such as in acute diverticulitis or acute appendicitis. And occasionally it will spread via the hepatic artery from chronic infection elsewhere in the body, such as infective endocarditis or chronic osteomyelitis. And most liver abscesses today are managed by percutaneous image-guided drainage. Here's a very typical example. This patient was quite sick and septic, and a very typical appearance of a liver abscess. In the right lobe of the liver, you can see liquefaction in that mass. But the pitfall comes with ultrasound sometimes when patients aren't so sick, and if you're imaging the patient early. And there's a process here in the liver, a very large mass, but if you saw that for the first time with no history, a liver abscess is the last thing you'd consider because it appears solid. And this is where CT is helpful. So if the patient is febrile, I would advise getting a CT, because CT is sensitive or more sensitive for the early liquefaction. And I think if I showed you the CT here, everyone would be very comfortable at suggesting that this might be a liver abscess. Now, in the last 5 minutes or so, I'll briefly discuss another mimic of acute cholecystitis, and that those are liver masses that rupture and bleed. And the famous two are primary liver tumors, liver adenomas, and hepatocellular carcinomas. There are others that can bleed, but they're the big two. And how do you distinguish those two apart when you see a ruptured liver mass? Well, yet again, it's the clinical history and the patient profile. So if it's a woman on the birth control pill and the background liver morphology looks normal, it's almost certainly a liver adenoma. On the other hand, if it's a patient with chronic hepatitis for 20 or 25 years, or if the patient has known liver cirrhosis, then that ruptured mass is invariably a hepatocellular carcinoma. So remember, clinical presentation, clinical history, always critically important. So here's an example. This is a young woman who presented with acute abdominal pain. We can see on the unenhanced CT this high attenuation free fluid in keeping with hemoperitoneum. And then we look at the tip of segment 2 of the liver. There's something going on there. It's not particularly clear what, but it looks like there's a big cleft. There's some high attenuation in it. Maybe it's a liver laceration, or maybe there's a large mass there that has ruptured. So there had actually been previous imaging on this patient when she wasn't acutely unwell, and she went straight to the operating room. So this is what a ruptured adenoma looks like in the operating room. And the reason these patients get into trouble is if the mass is subcapsular and it ruptures freely into the peritoneal cavity, often the bleeding won't be tamponaded and you can get quite significant blood loss. If the mass is centrally within the liver, then those masses tend to bleed less because the liver will eventually apply enough pressure to help control the bleeding. On the other hand, this patient has a history of chronic hepatitis for 20 years. Similar presentation. I'll show you the ultrasound images here. There was a mass hanging exophytically off segment 5 of the liver, and this is at one appearance of acute blood in the peritoneal cavity, quite echogenic, heterogeneous, so we were quite comfortable making the diagnosis here of a ruptured hepatocellular carcinoma with hemoperitoneum. And then the final case is a distinctly unusual case. This was a Saturday night in Toronto. This woman in her mid-30s, a mother of 2, came in with acute abdominal pain, and the initial ultrasound images showed this large heterogeneous mass in the liver. There was free fluid, a CT was done, and on the unenhanced images you see that large mass with some high attenuation. There's high attenuation fluid in the pelvis, so hemoperitoneum. She did have a history of being on birth control, so we said, well, it's a ruptured adenoma. But what a surprise we got when we gave contrast and we saw this peripheral nodular enhancement. So this is actually a giant cavernous hemangioma of the liver that had undergone spontaneous bleeding. Now, if you review the literature on this topic, you will find case reports of giant cavernous hemangiomas bleeding with minor trauma, maybe 1 or 2 reports in pregnancy, but it is distinctly unusual for a giant cavernous hemangioma to undergo spontaneous hemorrhage. So that brings me to the end. I'll just briefly summarize. Remember, be very slow to diagnose acute, uncomplicated cholecystitis if the gallbladder is not tensely distended. Remember, if you're considering the diagnosis, to try and look for the obstructing stone in the gallbladder neck or cystic duct, because it'll add confidence if you can find it. Remember always, whenever you image the gallbladder, keep in mind the possibility of an underlying gallbladder cancer. And if you think there may be a cancer, alert your surgeon to that fact. Remember, if you're trying to distinguish air from calcium, the best way to do that is the characteristic of the shadow. Remember, if we're talking about CBD stones and you identify a stone confidently with ultrasound, that patient could go directly for definitive management with ERCP. Remember, if you think there's a stone, but you can't prove it with ultrasound, you can't see the area of interest, and that will happen no matter how much ultrasound experience you have, and you don't have ready access to an MRCP, you can use an unenhanced CT scan that will add some sensitivity. You won't get to 100%, but it will often be helpful. Remember, if you see a cystic mass somewhere with ultrasound, just put on Doppler. Every so often you'll get a very big surprise and discover that you have a large aneurysm on your hands. And remember that early on, liver abscesses can appear solid on ultrasound. So have your wits about you. I've seen a few liver abscesses over the years interpreted as solid liver masses. And remember, with ruptured masses, the way you sort that out is the patient profile. Are they at risk of an adenoma, or are they at risk of hepatocellular carcinoma? Thank you very much. Again, a few references if you're interested. They're in your handout.
Thank you very much.